Hello everyone, my name is Adam Mead. I'm a haematologist based at the University of Oxford, and we're here in Lisbon at the iwMPN meeting, where we've just had a terrific session focused on accelerated blast phase MPN and transplant in myelofibrosis. And I'm joined by my panel members who I'll hand over to introduce themselves. Charlotte.
I'm Charlotte Brierley. I'm a clinical lecturer at the University of Oxford.
And I'm Juan Carlos Hernández-Boluda, and I'm a hematologist working in Hospital Clinic of Valencia, Spain.
So in this panel discussion, we had a number of presentations really focused around accelerated blast phase and some of the challenges of managing those patients in when they progress from chronic phase of MPN to accelerated blast phase. Dr. Brierley discussed her recent paper in Nature Genetics, which maybe you could tell us a little bit more about.
I think the paper mainly just shows the power of really profiling the disease biology in these cases and demonstrating that how much we can learn from molecular biology and how important it is to integrate molecular phenotyping into our clinical trials design, in particular in these patients who have a really poor outcome at the moment and represent a big unmet clinical need. So I spoke on, and you can look up the paper for the full detail, but I spoke about the fact that deploying state-of-the-art molecular biology techniques has allowed us to identify a rearrangement on chromosome 21 that wasn't hitherto appreciated, and it appears to be that this is a genetic driver of the disease, and it might indeed be targetable if we can come up with the right clinical trial setting to test it in.
One of the kind of repeated issues that came up for discussion is whether we might find better ways to, or biomarkers to identify the patients who are on a trajectory towards a very aggressive disease, so that we might intervene a little bit earlier. I mean, obviously there's a lot of activity and attempts to do this. Do you want to summarise where we are now and how we might go about trying to improve those approaches?
Yeah, so I think we have, from the risk stratification systems that we have an appreciation of who the bad players are, and often in clinic I think we will know who the patients are that we're worried about, but it's still difficult to know exactly at what point to intervene, and as you were saying, the timing of when to transplant is a really thorny subject. And I think there's still lots to be done about understanding where how that latency of the disease is impacted by the molecular biology, and really understanding what the drivers and also restraining forces in some of these cases on the clones, because there are some that don't progress.
Yeah, Adam, I think we have a consensus that the limitation of the treatment that we have now in the accelerated and blast phase, and actually, as you said, the need to intervene before, maybe due to biomarkers and so, but I think we have some consensus that the blast cell count in peripheral blood we can actually act before the patient actually fulfills the criteria, WHO criteria of accelerated phase. With more than 4% of blast in peripheral blood, probably could be a target for intervening with some disease modifying or trying to change what we are doing currently in clinical practice, maybe in clinical trial, or just with the tools that we have, like interferon, trying to decrease the clone and so on. I think there was a kind of consensus that something should move in that direction.
Right, yeah, absolutely. And you gave a nice presentation on transplant for myelofibrosis, and there was some good discussion about the timing of transplant. And this definitely comes up a lot, right? That patients maybe are scared by the risks and decide to go with a JAK inhibitor, and then they slightly disappear from the transplant center, and then they come back when things are very advanced. Yeah. So do you want to kind of give us your reflections about that and how we might think about improving this?
Exactly. Well, I mean, I think we currently have very good prognostic tools to identify patients that have what we call high-risk myelofibrosis, which is an expected survival of less than 5 years. But this is very broad. So many patients, when you explain what a transplant and the risk of transplant, they don't want to actually be submitted to such a risky procedure up front, and they want all these medications that we have currently. So it's fair enough, but the problem is that you have to use this tool when the patients have good clinical condition, have a spleen response and so on. So the monitoring is very important. So you can start medical treatment, no problem to my point of view, but then it has to be kind of controlled by some myelofibrosis specialists or so on. It cannot be just be in a small center with the lots of disease entities that these physicians are taking care of, and they don't actually are active enough or proactive enough when the disease is transforming. So I mentioned this in my talk because I think that in clinical practice is one of the main issues in this. Not so much if the patient has to be taken upfront, but not too late because of that, inadequate monitoring.
Yeah, just you need the timing just spot on. Yeah.
Yeah.
So one of the kind of repeated subgroups of patients that came up, and I presented a case history with patients with P53 mutation. So maybe both of you can comment on this. Maybe Charlotte, first you could comment on why you think these P53 mutant patients have such an aggressive, kind of terrible disease trajectory, and then maybe a comment afterwards about transplant in these patients with P53 mutation, if and when you should do that.
So I'll start by saying that there has been an increase, a new insight into the biology of this disease in just the last couple of years. I mean, the allelic status of TP53 is very important, and that should be something that we should be looking at routinely when a P53 mutation is detected. The other thing is that they clearly behave differently in terms of the impact on the genome of these patients, and they often develop widespread aneuploidies and chromosomal instabilities, and that clearly is a sign that a patient is going down a bad trajectory and transforming into a much more aggressive disease. And I think it's that process of generating aneuploidy that somehow seems to dysregulate the cell in such a way that really our current treatments just do not in any way suppress that clone. But I think there are some signals in the biology that there might be other treatment targets that we might be able to think about in future. I guess the other point is that clearly these TP53 mutant clones also in other myeloid disease contexts are exerting an impact on the microenvironment that becomes very immunosuppressive, and how we target these interactions between mutation, inflammation, immunosuppression, that's all not worked out yet, but there is some hope that as the disease biology is better understood that we might be able to target that as well. For now, transplant is our only option, but as we saw, it's not a good option.
Yeah, but I mean, going to what you have said, which I totally agree, is the allele burden is very important because you have many patients with ET and PV that they have a very small clone of TP53 and they are stable for many years. So it's puzzling how these patients are just behaving like this. Now, if we did identify these patients, we probably would select interferon in place of, for instance, hydroxyurea to these patients. But even with hydroxyurea, they have stayed there. We have looked at that retrospectively for many years. So the allele burden, I think, is very important. Once they are in myelofibrosis, for instance, in our database, again, 10% of allele burden discriminates to different prognostic groups. But I would suggest that even lower allele burden should be considered as an adverse prognostic factor in myelofibrosis because now you have more heterogeneous or complex molecular abnormalities in this disease. And we don't have good treatments for this, is for sure. Even transplantation, the results of transplantation, particularly if there is multi-hit TP53 mutation, and they are very, very, very bad prognosis, but it's the only potential tool to have long-term survivals with this type of mutation, multi-hit TP53 mutations.
One of the things that I think is interesting about the multi-hit, and they are very bad ones, but those multi-hit patients must at some point in time have been a single hit, right?
Yeah, yeah.
And they must have been a small clone before they were a big clone. So the question for me is if you can identify these small clone patients, but identify which ones are on that trajectory towards multi-hit status and which ones are just going to stay stable. One of the things we're trying to do in our lab is tackle that with single cell genomics analyses to really pick out whether, even when there's a low allelic burden P53 mutation, is it a multi-hit clone already at a very early stage? And maybe if you took those patients to transplant early because you knew they were on that bad trajectory, possibly you might see better outcomes.
Another thing is that in our current recommendations, we say, for instance, NGS only for patients considered candidate for transplant with myelofibrosis. Probably now is the time that we should use NGS also in ET and PV at diagnosis, at least in the younger patients, to identify these small clones and try to, because now the recommendations is only this selected population of myelofibrosis candidate for transplant. But I think this is the time probably to move forward and do that in the earlier stages of these diseases.
Terrific. Well, lots more work to be done. It was a terrific session. Thanks very much for taking part, and thanks everyone for listening.